Bismillahirrahmanirrahim.
At the starting of this course session in Stricture, what my intention is that basically what all have in their mind is that stricture urethra is a male predominant pathology. It is, yes, but there's also some amount of stricturing in the female as well. So the etiology epidemiology is somewhat similar to both the genders. So as we go on this presentation, we'll discuss the reviews in both the genders.
Bismillahirrahmanirrahim. Today our topic of presentation is Stricture Urethra, the very basic introduction. Objectives we will cover today will be introduction, brief basic anatomy, epidemiology, and evaluation of stricture. Multiple definitions are here of stricture, but concisely it's nerving of urethra due to spongiofibrosis, and it's defined as urethral stricture refers to a narrowed segment of anterior urethra due to a process of fibrosis and cicatrization of urethral mucosa and surrounding spongious tissues, means spongiofibrosis. In male posterior urethra, there is no spongious tissues, and at this location, the term stenosis is preferred. So, posterior urethral stricture term, there is no such term being used. And the definition of meatus stenosis is generally accepted as a short distal nerving at the meatus without involvement of the fossa navicularis. While in female, there is no such universal definition, but on the basis of various studies, it has been decided that as the reduced urethral caliber and defined as less than 14 FR, and nerving of urethra less than 14 FR as being labeled as diagnostic, compared with the normal urethral caliber of 18 to 30 FR.
The definition in female, the first line is right. There is no definite definition. Now, this definition comes from evaluation and anesthesia, in which calibration of the urethra is done with the help of Nelson catheter or in which the caliber is tried to be assessed. So anything which is less than 14 FR, it comes into the clinical definition of urethral stricture. But there is also a radiological definition. That radiological definition is that there is decreased caliber of the urethra distally with ballooning of the proximal urethra. That is the radiological definition seen on MCU.
And in general, as I said, refers to the fixed anatomic nerving of the urethra so that the lumen will not accommodate instrumentation without disruption of urethral mucosal lining. Again, anterior urethral stricture refers to the scoring process of corpus spongiosum resulting in the nerving of urethral lumen. Posterior urethral stricture are not included in the common definition of urethral stricture. Posterior urethral stricture and posterior urethral stenosis are more appropriate terms used for the nerving of posterior urethra. It has been decided according to the last international consultation of urological disease and urethral stricture held in Marrakesh 2010 that obliteratory process in the posterior urethra that has resulted in fibrosis and is generally the effect of dissection in that area caused by either trauma or radical prostatectomy. So posterior urethral strictures are either related caused by trauma or post procedure like radical prostatectomy. Basic anatomy is the anatomy of the we are discussing basically the anatomy of only male urethra. It's 18 to 22 or 20 centimeter long and extends from the internal urethral orifice at the bladder neck to the external urethral meatus at the tip of the penis. It has been divided into two segments: anterior urethra, which is further divided, classified into meatus, fossa navicularis, penile urethra, and bulbar urethra. While posterior urethra has been subdivided into membranous and prostatic urethra. A bit about prostatic urethra. It's 3 centimeter in length, and it's the widest part lies near the anterior surface than the posterior surface of the prostate. On the posterior wall, there is a median longitudinal ridge, urethral crest on both sides of which there is shallow depression called prostatic sinus. At the middle part of crest, there is elevation verumentinum, which mark the position of external sphincter. Membranous part of the urethra, it's shortest part of the urethra and 1 to 2 centimeter in length. At its least dilatable and surrounded by fibers of external urethral sphincter. Urethra perforates through the perineal membrane, after which it becomes bulbar urethra about 1 inch below and behind the symphysis pubis. Penile urethra is about 15 centimeter long, and it passes through the bulb and then surrounded by carpus spongiosum. It's uniform in the diameter of about 6 millimeter in the body of penis, but it dilates in the bulb to form intraburbular fossa, and it glands and forms a naviculous fossa. An image here. This is a posterior urethra. From here and till the ejaculatory virumentum, it's a prostatic urethra. The nervous part is membranous urethra, then the bulbar urethra and penile urethra. Here are two sphincters of urethra. Internal urethral sphincter, which is made of smooth muscle fibers, involuntary in nature, and supplied by sympathetic nerves from T11 to L2. It controls the neck of the bladder and prostatic urethra above the opening of ejaculatory ducts. External urethral sphincter is made of striated muscles, voluntary in nature, and it's supplied by the perineal branch of pudendal nerve from S2 to S4. It controls the membranous urethra and responsible for the voluntary holding of urine. Short about blood supply. Internal pudendal artery divides into bulbourethral and dorsal penile artery, which further the bulbourethral artery divides further into bulbous branch, anterior branch, and carpus spongiosum, while the dorsal artery gives further branches to carpus cavernosum, and before entering it gives a branch to cavernosal arteries on both sides. Epidemiology.
Now, this was the male anatomy. In the female, what the anatomy is that the urethra is a shorter length length tube. It is surrounded by the muscles in a horseshoe shaped fashion, in which the roof of the horseshoe comes on the dot and it is open ventrally. Yes, the external part of the urethra is surrounded by the sphincter urethral muscle. So that gives the continence mechanism to the female. So what is important is the urethral muscle, that the shape of the urethral muscle on the dorsum of the female urethra. So that is the major difference between the musculature surrounding the urethra of the male and the female. So why is it horseshoe shaped and how we use it in the surgery? We'll discuss it later on when we come to the surgical part.
And males' mean age is about 45 years old. The anterior urethra is most frequently affected, about 92%, particularly in the bulbar urethra. While in females, the incidence increases over 64 years old, and a true stricture occurs only in 0.08 to 5.4% of women with refractory lower urinary tract symptoms. In children, most strictures are traumatic. Iatrogenic causes are caused by iatrogenic or external trauma. Pathophysiology: the spongy erectile tissue of the carpus spongiosum underlies the urethral epithelium, and the scarring process extends through the tissues of the carpus spongiosum, and in some cases in adjacent tissues. Contraction of this scar reduces the urethral lumen. While looking at this image, while at the very first image that we see on the right side, there is a mucosal fold just arised from its normal. While moving onto the second image, we can see there is a significant involvement of the, and there is fibrosis started in the spongy tissues. Similarly, as spongiofibrosis, bulk of spongiofibrosis increases, the urethral lumen decreases in size. But etiology: any process that injures the urethral epithelium or the underlying carpus spongiosum to the point that healing results in a scar can cause a urethral stricture. There is a broad categorization of urethral stricture into iatrogenic, most common about 32 to 79%. Infections mostly caused by sexual transmitted disease about 40%. Idiopathic, inflammatory, and traumatic. First, iatrogenic.
Can any all those who are in COPD, we rarely see an OPD paper which has the etiology of the stricture written on it. It's just a simple stricture urethra and then the story goes on. Why is the etiology so important? Can anyone tell me? But every time when we're in the OPD, everyone, Professor Manzoor, me, Dr. Tandeep, Dr. Usman, all ask what is the cause of the stricture? What is the etiology? So why are we so concerned on the etiology? So the treatment option, the treatment that you are going to pursue in a particular patient depends on the etiology. If it's an infective stricture, and infective stricture, you need to first clear the infection, then do an endoscopic procedure. You have, for example, if you have a patient who has lichen sclerosis, no matter how many endoscopic procedures you do, it is bound to reoccur. So you need to offer him something else. And again, if it's a traumatic stricture, then you need to understand that you need to go into more expensive surgery, probably use grafts. And if he has a previously failed surgery, then all this depends on the etiology of the mechanism that has caused the stricture. Infective strictures probably they tend to reoccur with endoscopic procedures because of the extensive fibrosis that is present because of the infection. So the etiology is very important in progressing towards the treatment of the patient.
First, discussing the iatrogenic. It occurs mainly due after instrumentation, either diagnostic or therapeutic endoscopic instrumentation, like we do procedure TURBT, TURP, cystoscopy. And multiple reasons are there. One is the instrumental cystoscopy in inexperienced hands, or the passage of two large size endoscopes, or end-welling catheters for prolonged period. Post-prostatectomy being documented up to 4% in cases, and post-amputation of penis. Mechanism, there are three main mechanisms of iatrogenic injury. This is the cause, poor technique instruments. The other is large, either it causes pressure necrosis, or we disrupt the urethral mucosa. Lifting up a mucosal flap can lead to a pulse passage, and this most commonly occurs at the penobulbar junction. Instrumentations or large size instruments or prolonged period causes ischemia of the urethra due to relative compression of the spongious tissues. The incidence of stricture following TURP prostate is about, that already discussed, 3 to 4%, and mostly occurs within the mid-bulbar urethra. After urethral catheterization, or when the balloon catheter has been blown up in the bulbar urethra, or if we pulled out the blood, we pulled out the catheter without deflating properly the balloon. Coming to idiopathic bulbar strictures, it's also one of the most common presenting in developed societies, and certainly the most common in young men. Typically found at the junction of the proximal and mid-bulbar urethra. It's usually short and tight, and patient presents in late teens to early adulthood. There is no specific cause, and it has been speculated that it may represent a problem with the blood flow into the rapidly enlarging penis during puberty and urethra in a susceptible patients. Coming to infections, mostly caused by the sexually transmitted disease. Urethritis due to sexual transmitted disease, and particularly gonorrhea is one of the most common in well-developed countries, but it has now been decreased to 40% from 70% of all cases. Site of stricture urethra caused by the gonorrhea mostly at the bulb, and 70 to 80% of the cases, and penoscrotal junction, distal part of penile urethra. And one of the characteristics of gonorrhea is, we will see in a urethrogram, yet there are multiple strictures. It has never been observed in the posterior urethra, and appears within 1 year post-infection, but symptoms may not appear till 10 to 15 years. Other infections like non-specific urethritis, tuberculous urethritis, or periurethral abscess. Congenital, it's rarely, very, very rare, and not defined properly, but based on studies, it has been decided that a stricture which is non-inflammatory, short in length, and not associated with injury or any potential injury or history of trauma in infants are termed as congenital. Most commonly it occurs at external urethral meatus and phenostrutal junction. Traumatic is one of the most causes, and urethra can be damaged by the passage of stone or some foreign body, while external trauma can also cause stricture urethra. Mostly it is straddle injury and pelvic girdle. There are two kind of traumas, injuries. One is penetrating injury, the other is non-penetrating, like blunt trauma. Penetrating injuries are very rare, and it could be a sharp object like knife, bullet, or other object, or may follow an explosion. While non-penetrating or blunt trauma injuries, it occurs in crushed injury of the bulbar urethra and dissection injury of the bulbomembranous urethra. A crush injury or pylostart injury, it affects mainly the bulbar urethra, in which a high velocity perineum is compressed at high velocity against a rigid object, which result in the bulbar urethra being compressed and crushed against the inferior pubic arch of the pelvis. The urethra is usually intact, but urinary extravasation may occur. Urinary retention is almost inevitable, and dense, full thickness stricture and obliteration of urethra is likely to occur. Pelvic fracture urethral injuries, mostly we see in our PD cases like this, caused by the blunt trauma. 10% of the pelvic fractures are associated with injuries to the bladder or urethra. Bulbomembranous urethra is mainly involved, while dissection injuries are unique to the membranous urethra. Like as we discussed, the motor vehicle accident RTAs, a fall from the height, which leads to compression of urethra against the bone. In females during prolonged labor, pressure of the fetal head on urethra leads to necrosis, followed by healing that leads to stricture formation. Urethral growth has no such effect, but if we apply therapy like radiotherapy for some urethral growth, that can lead to a stricture. Complications caused by the stricture are due to outflow obstruction. There is gradual dilatation of the proximal urethra and bladder outflow obstruction, so compensatory bladder hypertrophies, and there are diverticulae formation leads to obstruction of upper tract hydronephrosis with hydroureter. Similarly, stasis of urine leads to infection, prostatitis and cystitis, and pyelonephritis. Bladder stones are formed, and infection of stagnant urine just proximal to stricture leads to periurethral abscess, which then ruptures and forms urethrocuteneous fistula. Our terminology, water can perineum, that urine leaks and accumulated in the perineum. Now coming to evaluation of urethra, as already shared by Dr. Mazahir, that before embarking on treatment, we need to know the etiology of the structure. Specifically, we should assess the depth, density, length, and location of the structure, so that accordingly treatment plan can be made. Diagnosis based on the history, specifically if there is any sexual disease history or there is trauma, so trauma need a specific history. Finding and examination, specific labs, sonographic evaluation, so we will discuss one by one. There are generally no signs, but structure may be palpable as a tough fibrous like structure between two fingers, and if there is periurethral abscess, then a tender mass can also be felt. Urethrocuteneous fistula is formed in long-standing cases, which can be seen. Symptoms are there is gradual decrease in the stream and caliber of urine. Sudden may lead to sudden urinary retention, and lower urinary tract symptoms like frequency, urgency, nocturia. Mostly such patient presents at younger age. Baseline investigations like to assess the renal function, urine culture, and serology to rule out venereal disease, and ultrasound KUB to see upper tract. Coming to radiographic evaluation, Basically, we do with evaluation of urethra with contrast by two kind of uretrogram. One is retrograde cystourethrogram and the other is antegrade cystourethrogram if there is SPC. And it helps in the determination of the extent and location of stricture, which is important to decide mode of management. Retrograde urethrography, we see frequently in our OPDs. It demonstrates the total length of the urethral structure, which cannot be negotiated by cystoscopy, and demonstrates the anatomy of urethra distal to a structure which may not be accessible by widening cystourethography. Technique is that a plain film radiograph is obtained before the injection of contrast. Then patient is positioned slightly oblique, and the penis is placed on a slight tension. A small catheter is inserted into fossa navicularis, and balloon is inflated up to 2 cc with sterile water. Contrast is then introduced via catheter tip syringe. We can use a clamp to occlude the urethra around the catheter. This is an image of retrograde urethrogram. We can appreciate penile urethra, bulbar urethra, membranous urethra, and prostatic urethra. This is one image of urethral structure at BMG, at bulbar urethra. This is an image of gonococcal structure urethra secondary to gonococcal infection. We can see multiple structures along the whole length. And ascending urethrogram or descending urethrogram, if SPC is in situ, so usually we can't assess urethra only on the retrograde uretrogram. If there is complete structure and contrast goes behind, so we use descending uretrogram, which this we can see in the second image. So we can appreciate now the structure length as well as the size.
So we use the combination of NBL and the antegrade uretrogram to eliminate the posterior urethra and evaluate the bladder and the bladder neck. In some ways, for example, if there's a complete obliteration of the urethra, not die going into posterior urethra, then you have a complete evaluation of the entire urethra when you use the antegrade study. In some retrograde studies, there's a doubt on the bladder neck. So an antegrade study can help in eliminating this doubt. But these retrograde urethrograms, they help in evaluation of the structure, but we've seen in a lot of our cases that sometimes the retrograde uretrogram is not as proper as the surgical finding that we get. But they do give you an idea on where the structure is, on how to go towards the management of the structure. How do you next step, so what we do is do a antegrade cystoscopy. And we reject. Are we able to reach the kind of? Yes, sir. Ideally, it should be done with a flexible cystoscope because we like to go right down to the proximal margin of the urethra. But since it is dependent on the availability, we have a rigid cystoscope. So what we actually see is we see the bladder neck, we see the presence of bladder stones, we see the bladder in general, we see the bladder neck. It's patenting with the movement of water, and what we like to see is the view. Now, when we see the view, what we have in our mind is that our dissection will be at least distant to the view. So the extent of surgery will differ. If you don't see the view, if it's distorted, that means you probably have to go for a spectacling or for a progressive approach. Yes. If they run to the posterior of the retrograde, that means there's a complete obliteration. In that case, the patient won't work. That patient won't probably have a problem. But in this program, we have got in the bulbar. Sometimes we find it in the bulbar penile junction, or sometimes in the penile
got very long length and on the other side patient is not opening that. In this scenario, I think the flexible is very important. We cannot test the stricture on retrograde.
So sonography, it's most sensitive and specific and detects urethral structures, about 98% sensitivity and 96% specificity. It gives an idea about three-dimensional study and the evaluation of the urethra without exposing the gonads to the ionizing radiation. The exact length and the depth of the structure and the severity of the structure segment as well as the anatomy of the peri-urethral scars are also assessed. Endoscopic evaluation, mainly we do with cystiurethropy with the flexible, either under the local anesthesia, or we can do cystoscopy with the rigid under GA to evaluate the site of the structure as well as nature of urethral mucosa. Pediatric cystoscope is also available in the evaluation of urethra proximal to the narrow segment. Cystoscopy from above can give about idea about the bladder neck and the verumentinum. Uroflowmetry is also used at objectively measures the degree of obstruction. We actually see the value of QMax, maximum flow rate. If there is not complete structure, so we can have a baseline value of QMax. And then after procedure, subsequent follow-up, we do post-op uroflowmetry and assess the success rate of the procedure.
I have a question, Dr. Naji, if you can hear me.
Yes, sir. We can hear you.
So unfortunately, we cannot hear anything about from the audience. We just could appreciate that Mazahir was talking sometime, and then there was a response voice, but we could not appreciate what they were discussing. So my question is to Stricture team that you have just mentioned that objective of measurement of degree of obstruction is just Qmax. We just look at the Qmax, or it is the entire film of the uroflowmetry that contains much more information apart from Qmax only? Because we have seen the patient that if you read just the marking of that Qmax, there appears to be like one of the graph is showing in that the machine will tell you Qmax of around 20-30, but actually there is a problem with the patient, like in straining and staccato curve. We can see peaks very high, but urination is not normal in such patients. And then there can be prolonged urination and voiding as well. And sometimes patient efforts by using skeletal muscle, the machine will tell you what was the Qmax at that point of time, but the actual flow rate can be very different from that Qmax. So do we look at the Qmax only, or we have to look at the entire picture?
Thank you for your question, Dr. Naveed. Qmax or Uroflow is one of the armamentariums in the evaluation of a patient of stricture. It starts from history and the etiology of the patient, and goes, and the next thing we see, what we evaluate is a post-void residual urine, and the Uroflow comes in between. When the provisional diagnosis of a stricture is coming, so we do a uretrogram. It is the definitive diagnosis of a stricture comes on a uretrogram and subsequent cystoscopy, because we need the complete evaluation of the stricture. It is not just that the presence of the stricture is there, but we would like to see the length and the severity of the disease as well. So a combination of all these features move towards the evaluation and coming to the diagnosis of a stricture. Saying on Uroflow alone that the patient has a stricture cannot be confident, because the uroflowmetry and the graph can be reproduced by many other elements of lower unit tract. Sir, have I answered your question, sir?
Yes, to very much extent you have answered my question. Basically, I wanted our resident to know that this is QMX is just one single parameter. Whenever we are talking about the urinary flow, we have to look at the entire picture: the graph, the QMX, phosphate residual volume, pre-wide volume in the bladder. Everything is very important. Then we can reach to any conclusion or any clue about the condition what patient is suffering from.
We're doing it. So, just a comment on the female strictures. The dilemma of female strictures, it becomes more difficult when you're coming to treating a female. Over here, you see that the strictures are in the male are commonly in the young because they're prone to STDs and they're prone to trauma. In the female, it is more, you can see the more commonly you can see it in females after the age of 40 and post-menopausal women. And the dilemma of actually evaluating these females of having urethral stricture is very difficult because there are about 50 to 60% of females who have lower urinary tract symptoms, and out of those 10% have a stricture. But out of all these patients, those who have a stricture are not only diagnosed on a post-void ultrasound or a uroflow, but the definition of the stricture comes when the patient undergoes a micturating cystourethrogram or retrograde, and then an eventual cystoscopy, in which you actually visualize that there is a stricture in the female. After that is when that this female in the females will be labeled as having a stricture urethra. So in the males, you have some sort of non-invasive ease to determine whether it has a stricture. You can see it on a retrograde urethrogram. But in the females, the diagnosis is, or the label is put when you see the stricture in the female.
And we used to discuss in past that when we use the term stricture urethra, it always should be used for the anterior urethra, not the posterior urethra. And as far as I know, females don't have corpus spongiosum, I guess. And so, can we use that same term stricture urethra for the females as well?
Sir, currently the articles which are going through the female urethral strictures, they have labeled it as FUS, female urethral stricture. They have not been using the word stenosis in these females.
So current vocabulary has changed, you mean to say?
Yes, sir. The current vocabulary is FUS or female urethral stricture. The FUS is now the abbreviation for female urethral stricture.
One thing more I want to add is in one of the slides, Dr. Najib showed us that there was one of the etiological factors for female stenosis or urethral stricture is prolonged labor. So, and prolonged labor leading to the compression of head against the pubic symphysis and then necrosis. So, I think this is the pathophysiology for the urethrovaginal fistula, not a stricture. Correct me if I'm wrong.
Sir, the etiology for the female for the fistula is there, but there have also been seen that they have also been associated with the female stricture as well. But however, I cannot say confidently because the population which has been researched in the past, the population number is very small. The largest population number that have been investigated till today is just 39 females spanning over a period of 10 years. So I cannot say confidently whether both the same pathophysiology leads to both, or it's more predominantly. But at this time, I can say that the pathophysiology that you have said, it is more predominantly for a vesicovaginal fistula as compared to a stricture because the data for is lacking in the female urethral stricture.
Thank you.
Last slide. Just to discuss UFM, there are curves, as Dr. Naveed said, that we should see at the curve and all the parameters of UFM. So just a few examples. That's a normal curve is a belly shaft like this one. If there is dysfunctional widening curve of detrusor activity, there is a tall tower shape, and while in the prolonged curve there is an BPH. And if there is neurogenic bladder, then intermittent flow curve we can appreciate. And urethral structure there is uniform this box variety curve, correct? Plate भी कहते हैं इसको, urethral structure. Thank you.
A very nice presentation, Dr. Najib. Sorry, I am just starting on my own. Actually, whenever you listen someone or read the book, we come to know something new about it. Previously, my understanding about the stricture urethra was if there is no fibrosis or corpus spongiosum, we cannot label it as a stricture. But one of the pictures you just presented in your presentation, there was mucosal fold that can be also labeled as a stricture. So this is something new that I came to learn after all these long years. And one more thing I would like to add regarding these curves, there is a term known as staccato curve. When you see the staccato and spraining patterns, they are kind of similar, but I think Mazahir can add in it the difference, how to label something as staccato curve and spraining curve. Just looking at the curve of the uroflowmetry, which curve we can label as a staccato and which curve we can label as a spraining pattern.
So what you see in the uroflow is that the patient strains to pass the urine, then he relaxes, then strains again. So this gives rise to the pattern, the staccato. I'm sorry, my pronunciation maybe the staccato pattern. This pattern is because he pushes and then he stops and then pushes again against the resistance of the urethra. So it gives rise to this flow pattern in patients who might be having strictures.
Actually, when I was in PhD, I presented about the uroflowmetry curve. I will look if I have my presentation with me. I will share with everybody. In staccato pattern, we usually find it in a pediatric population where their external sphincter is due to the behavioral learning of avoiding pattern. Their external sphincter is behave like an involuntary sphincter, where during voiding their external sphincter contracts and then relaxes itself. So there is a complete interruption of urinary flow. And in a spraining pattern, there will be continuous flow of the urine with peaks and troughs.
BXO is or lichen sclerosis. It is a pathology of the keratinized epithelium skin. So now you can see that the BXO starts from the most distal part, from the external urethral meatus, and it keeps on involving the penile urethra. Now the problem with BXO is that once that stricture is formed, so if you do any other endoscopic maneuver or you replace the urothelium with the urothelium, since it is a pathology of the urothelium, it is most likely to reoccur. So in the treatment of BXO, you need another form of endothelium. Now the second question, that whether you would like to treat it as a stricture or a prostate in the old age patient, is the distal pathology first. You treat the distal pathology and see how the urine, the symptomatology of the patient, how it improves, and then once you see that the distal obstruction has been relieved, then you can come proximally towards the prostate. So it is a dilemma in which you have a stricture as well as a prostate. It requires close coordination with the patient symptomatology and the required investigations that can give you the idea on where actually the problem will lie.